Today we have to talk about cryoablation. We had an agenda that was focused on the FDA clearance discussion, although there isn't really an hour worth of discussion about that, even though it was a 9-hour meeting. But we can hit on some of the highlights. And a couple of the things I want to talk about today regarding the Frost trial update and the DCIS trial update. Um, and then if you have any other discussion points, we can also discuss those. But let's start
Okay.
with our usual introduction. I'm Dennis Holmes, a breast cancer surgeon. You are?
Sharon Merritt,
Okay,
patient advocate.
right. And this is
Actually, more than patient advocate. Susan Komen, science advocate, and an Alamo scholar, I guess. So
you're
that
here.
sounds better.
You're here.
Yeah.
And today we're having the latest iteration of the breast cancer Q&A webinar, which we do about every 2 months, although this one is a little delayed from last month. So maybe we'll do one next month to get back on the every other month schedule. But those of you who have heard about the announcement have heard about the FDA consideration of cryoablation as a treatment option for early stage breast cancer. So let's start to see if you have any questions about that, and we can go from
Where are they at?
there.
What are they thinking? I heard some at San Antonio, but not very much.
Right. So as you probably know, in November, there was a meeting of a panel of scientists and clinicians and statisticians that
Hopefully some consumer advocates
there
too.
were I'm sorry, there were advocates as there as well. It's patients who had received cryoablation who are part of this a committee that evaluates technology for approval by the FDA. They're not the decision-making body, but they get to hear the evidence, the
And
pros and
make
the
a
cons,
recommendation.
and make a
I've
recommendation.
been on one of those.
Oh, you have?
Yes, I have.
Yes. Well, then you have a living experience of what took place in November. And the hope was that there would be, support behind this question. And the question was quite specific. The question was, can the ice cure device, so
Okay.
it's a very specific device approval.
Yeah, because I think Ice Cure was there too, correct?
Right. It was only about ice cure.
Okay.
It wasn't about cryoablation in general. It wasn't
Right.
about any other technology.
Just Ice Cure.
The trial that was done, and maybe we should talk about that. The trial that was done was called the ICE3 trial.
Mhm.
It was a trial that utilized only one device, the ICE3 cryoprobe, and that trial was used to treat women with specific criteria for their breast cancers. There were women over the age of 60 with tumors 1.5 centimeters or smaller. All the tumors were ER positive, PR positive, and HER2 negative.
Why is it they always
In
leave
there
out her too? Well, we'll get to
for
that
lots of
later. You
reasons.
can tell
For
me
lots of
later.
reasons, rightly so, but
Yeah.
but rightfully they did so here, and they had no evidence of lymph node involvement. And the study basically said that all women that qualify would receive cryoablation. They encouraged everyone to have anti-estrogen therapy. About 80% of the patients agreed to take it and actually took it. The use of radiation was optional. Only I think about 7% of patients had radiation, and or maybe it was about 10%. And the use of sentinel biopsy was optional, and it was something like maybe 10% of patients had sentinel biopsy. So most patients just had cryoablation and medication. They had no radiation. They had no sentinel biopsy. And the trial showed, with 5 years follow-up, that there was approximately a 3% recurrence rate amongst these 194 patients that participated in the trial, which is pretty comparable to most other studies that are done in which women in this age group get lumpectomy and no radiation and then take medication.
Right.
There are various other trials that look at omitting radiation for people 60 and older, and they generally show about a 3% recurrence rate in 5 years. So it was comparable. And so IceCure basically went to the FDA and says, hey, our device achieved these results that are comparable to the surgery results without radiation. Please approve our device for use of cryoablation.
In breast cancer.
In breast cancer, right. And so there's this, 9-hour meeting where all the foes, and the cons and the pros were presented. And at the end of the day, there was a vote, and the vote was in favor of recommending the FDA recommending to the FDA approval of this technology for this specific indication.
Right.
Right. So it doesn't mean that it would apply to people with 1.6 centimeter tumors or ER negative
But it's a
tumors,
start.
but it's a start. Yeah, it's like you're getting your foot in the door, and then you can open it up more widely. So that is the question before us. Will it be approved? The decision hasn't come down yet,
It takes
but
a while.
I'm told that there will likely be a decision before the end of March.
Oh, good.
Right. Uh, and so what is that decision? Well, it's both good and mixed.
Oh, okay.
So likely the hints are likely that it'll be approved with some contingencies. So what are the contingencies? I don't know what the contingencies will be, what are possible contingencies. It could be that they will approve it for an even narrower group of patients, like
Mhm.
maybe for 1 centimeter patients,
Or maybe for people that can't have surgery.
or maybe just for people who can't have surgery, or maybe for people that are 70 and older, not 60 and older.
True.
They will, you know, they can massage your data to say, well, amongst this population of
Mhm.
194 people, the lowest hanging fruit are these, this 100% that met 100 patients that met these criteria, and therefore we approve these criteria, and we want more data about these criteria.
Hopefully the ones that had reoccurrences were older.
They're older, older, but yeah,
I mean,
I can't remember the ages of
oldest in the group,
yes,
maybe.
but I can't remember which ones they were, and if they took anti-estrogen therapy or not, or if they had radiation or
Right.
not, or if they had a system biopsy or not. But that's kind of what someone is deciding. Some entities are deciding. People are deciding. Um, it could be that we will approve this, but like only for a year or two. But in the next year or two, you have to give me more data about these. So it could be approval of the whole group, but contingent upon more long-term follow-up on a certain point. Like they want to see their outcomes over 7 years, not just 5 years, for example.
Mm.
Uh,
If they do that, can you add more data?
yeah, that would be, they would basically be asking for them to enroll more patients or follow these patients longer. It would be that, or both. That could be what they ultimately
Well, I'm
decide.
sure they can always find more patients.
Yeah. But it's just, it's just a costly endeavor to do clinical
Oh,
trials.
yeah.
And so, it's not something they want to do, but it it's a good sign. So that's kind of the most likely possibilities that it's going to be approved to some degree. And there's a reasonable possibility that they will ask for more data regarding something. It's kind of like a compromise. And then what comes next? Well, the process of getting it FDA approved and covered by insurers is a process. And that process doesn't end with a decision to approve. So the next thing that happens is what the company is seeking from FDA is approval for an indication. Is they're basically saying, I want you to approve the use of this device for this specific purpose. And that purpose is called an indication. That is cryoablation of breast cancer for women that meet these criteria.
Which are very
Uh,
strict.
they're strict,
Way too
but
strict. But
as you say,
anyways.
it's a start. And then once the FDA approves it, then it has to be included in guidelines. And the guidelines are mostly society-based guidelines, like breast cancer community guidelines. So the American Society of Breast Surgeons has guidelines regarding cryoablation. ASCO, American Society of Clinical Oncology, probably will have guidelines regarding this. The various, societies of
Right.
clinicians will weigh the data and consider what the FDA has to say about it, and then make recommendations. And the guidelines may be more narrow or slightly broader. But these are the guidelines that need to happen before it can be considered for insurance coverage, because insurance companies, they want FDA approval, but they usually approve things based on guidelines.
Right. They usually follow Medicare, don't they? A lot.
Yeah, but not necessarily, and not necessarily immediately.
Well, yeah,
Yes, yes. So the next step after the indication, which we hope we'll get for something, is will be an effort by the company and by advocates to get the societies and members of societies, get the societies to endorse the use of cryoablation in their guidelines for certain for patients with certain criteria. Uh, and then those guidelines will be considered by health plans. So that's the next part. So indication first, guidelines second. And now the hard part comes, which is a billing code.
yes.
Yes.
It has one now, but it's like a middle of the road one.
Like a
It's like
like a low road one.
yeah, it's kind of a, what's the word I want? Um, like a trial one, or I can't think of the word I want,
Well,
but
the word we use is a category 3 code.
right,
Yes, the codes are in different categories. And a category 3 code is an administrative process that basically says this is a new technology. We don't know if it's going to be something we're going to be using in the future. We don't know if it's going to be used enough to be worth giving it going through the other processes of getting it a higher level code. So we're going to give you this tracking code
right,
so that every time it's used and it's billed for or registered under this code, we'll have a database of the number of times, the number of places it was used, and for what, right?
right,
And so, but it doesn't have anything to do with the payment. It's just a tracking.
right. Does that code, how do they follow people like that go to you off protocol? If it's not billed, then they don't know what
Well, the
happens, right?
company knows that I'm doing it because based on the device
Right,
purchases. And so even though I don't, when I complete the charting, I do include the code, but I don't bill the insurer for the code. But the company that's selling devices is tracking the use of the device. So they have the data indirectly.
I also know a lot of the patients are trying to build their insurance companies, so I guess that would make it show up some.
Yeah, but it's not gonna be, it's gonna be lots of, some will, it's gonna be incomplete. So the person that has the most complete data is the company who knows
Yeah,
whether or not every device was used because they can track it in the machine. Like
oh, that's
not only
true.
did
I
I
didn't
buy
even,
it,
yeah,
but it actually was used. So they have all the data regarding the usage. Uh, and they can say, there were 5,000 cases done and 200 in California, 100 there, and drill it down to the office where it was used and give that to the FDA and says, look, we have these 5,000 cases done in 2024, is being used and it's growing from 2024 to 2025, whatever.
right,
So the counting, the code is what the government would use to validate that these things are happening. And then there is a process that involves the American Medical Association and the various societies that have an interest in this to develop a category 1 code, which is what I won't say it's a holy grail, but it's the thing that
you can bill.
has a value assigned to it that will allow a doctor, radiologist, or whatever to bill for it. And it is anticipated that that process will take about 2 or 3 years. The category 3 to category 1 transition process. And so what does that involve? It's like I say that it's like trying to get a bill through Congress.
Yeah, believe it.
There are interested parties and there are opposing parties to
That's a
everything.
question I have for you too.
Yes.
The surgeons, I've seen a lot of them that oppose it.
Yeah.
And I wonder sometimes, do they oppose it because they can't read an ultrasound?
For example.
Because you have to be able to read an ultrasound to do it.
Right. I mean, there are a number of, those are like individual surgeons, but like I'm saying, there are individual surgeons that don't have ultrasound skills that might oppose it because they can't do it.
Right.
But it's also bigger than that, meaning that, so first of all, as you said, there are interested parties and opposing parties because
Right.
if people can't do it, then they might be opposed to it. but they're not necessarily speaking for the society, they're speaking for themselves. But at the society level, what you have is, say, in American Society of Breast Surgeons, you have 3,000 surgeons members. And this is one of the good societies, meaning that there are a
Yeah,
lot of
no, I
people who
know.
do ultrasound within the society. But of the members that do ultrasound in the society, probably 10% of them are certified to do ultrasound. So that's three, so 2,500 people, don't do it, 500 people do it, whatever the math is. It's a small number of people, the 300 that do it, uh, that are certified to do ultrasound. Now, the society represents all 3,000 members, not just the interest of
Right,
the 300 that do cryoablation and want it to be advanced. Uh, so the society has to advocate for what benefits the whole, not just the smaller part. Um, Now, where it gets even more complicated is that there is this system of placing a value on a code that requires that you consider how much work effort goes into that versus the related procedures. So let's say this is a breast code. It's going to be a breast code. Well, the breast codes includes mastectomy, lumpectomy, lymph node biopsy,
and they all take a lot longer to do.
or not.
Well,
But they
a
all
lot of
take but
times.
they all take a certain amount of work effort. So your point is they take a certain amount of work effort. Uh, and so a part of the process of figuring out what the work effort is they survey, people that do cryoablation and do lumpectomy and do whatever. And it says, well, quantify the amount of time and effort that goes into your mastectomy, quantify the time and effort that go and compare it to cryoablation. And so there's this work effort survey that they do with people that do the various procedures. And then they come up with like a scale, like mastectomy is here, lumpectomy is here, cryoablation is here, lymph node biopsy is here. And the relative value of them is mapped out. And that's the first challenge. And then the second challenge is, it's not like they say, okay, we have another thing we want to do. Let's add another slice to the pie. It's not like you have a pie plus a slice.
Yeah.
They're not adding minute today, but they say, we have a pie. And now you want me to squeeze in cryoablation into this pie. So that means they have to take a little bit from mastectomy and a little bit from lumpectomy, and a little bit of
Oh,
sentinel biopsy to create a little slice or a sliver for cryoablation. Uh, you see how it gets political. And so everyone who does mastectomy will compete to maintain value in mastectomy. They don't want to give up any value to cryoablation, especially if they don't do it. Everyone who does lymph node biopsy wants to keep the value of lymph node biopsy. They don't want to give up a little bit. And with Medicare cuts that are already happening,
yeah.
the supply is getting smaller overall. So every slice is getting smaller. And the more you have to divide it up, the more political and competitive the process gets.
And how does, because they do pay for it for fibroadenoma.
Not very much.
I know it's like 2,500
Maybe.
or it's what I saw,
Yes.
but
And the device costs more than half of that.
right. And so that's why I'm thinking that they'd probably look at that too and say, well, this is what we pay for that. And it's
Yeah,
basically the same
although
thing.
it is and it isn't, because
Okay.
with cancer, the counseling process, the liability, and all of that is very different than a
Yeah,
benign thing
true.
that can be left alone. So, it's appropriately lower than for cancer because of all of the stuff that goes into managing a cancer patient that's included in that global price, as they call it. You know, so that's why it's not an easy process. The same process that is happening in the surgical community is going to happen in the radiology community because they're users as well. And they do various radiology procedures, and they'll have to compare cryoablation to the other procedures and negotiate a price that's equitable, that,
They're not losing money.
they're not losing money. I mean, there's going to be money lost from something, but that, it's at least it's fair and it's equitable. That's all I can say is whatever equitable is, it has to be everyone has to be equally hurt. you know, I mean, every code has to be equally harmed, and so no one can be free of harm, and no one can receive all the harm, you know.
The interventional radiologists will probably be more for it than surgeons, maybe. Because a
There,
lot of them already do it.
yeah, there are issues with that though, but so that's one challenge. Now the other challenge is that most surgeons that do cryoablation are self-employed or they work for themselves. Uh,
Yeah.
self-employed, but they work for like a group, you know, where they have to buy the equipment and they have to deliver the treatment. Most radiologists work for a corporation. So they don't have to buy, the
Right.
radiologist doesn't have to buy the equipment. Someone else is buying the equipment. So they don't have to worry about how much am I paying for this
Right.
probe and how much am I going to get paid for the procedure. It's a little bit more removed from now. Someone has to do the accounting,
Mhm.
but it's a little bit more removed from them. Uh, but the math has to work long term because if they're doing it and they're not getting reimbursed adequately for it, it's not going to survive within. It's going to be discontinued. Once the bean counters start looking and say you're losing money here, then they're going to
Yeah.
say, well, you can't do this, or we have to do more. So it's not okay that it's being done at at minimum or no profit
Well,
because
for
it's not
sure.
sustainable, right? Uh, and that's also true for the surgeons that it has to be sustainable if it's going to be done. Otherwise, people will do what reimburses them more reliably, uh, because they have to pay bills and so forth. And to do it in your office, you have staff overhead, you have equipment overhead, you have the supplies, you have the piece of the cry probe, and so
And the
it can
machine.
in the machine. I mean, fortunately, most of us don't pay for the machine; they just allow us to use the machine if we buy the probes. But
Oh,
maybe
nice.
you have a different arrangement where you own the machine and you get the probes at a different price. Anyway, the point was that it has to be equitable. But there is this complicated process that takes about 3 years to come up with, or 2 to 3 years to come up with the actual price. And it's not like just someone says, well, this price seems right. There's
So
this
basically it's
lobby.
starting, but it's not going to happen soon.
It won't start until there's a,
No, I
it's
mean,
a,
it's starting to go through the process, but it's not going to happen soon.
no, it hasn't started to go through the process. The
Oh, okay, yeah.
yeah,
It has to be approved first.
right, because the process is so laborious and so time consuming that it's kind of not worth the investment unless you have an indication. So uh, sorry, and unless it's in guidelines. So there has to be a process of it completing, getting an indication. So maybe for the first quarter, into March, there has to be a process of getting it in guidelines. And that might take a year or more to get it in the guidelines because there's usually like a schedule
Mhm.
when when these societies evaluate technology and then have the meeting and then release the guidelines. It's not like you just do it ad hoc. There's usually
No,
a
I know,
process
because
to it.
I was in one of the CMDR ones,
Mhm.
and you spend a lot of time reading through everything, giving your recommendations, then you had a meeting, then you could change your recommendations, then there was another meeting before it ever got to where you were at.
Yes. So how long did that take?
About a year,
Okay.
or
So
well, maybe 6 months.
yeah. And so, but these meetings the societies work at different schedules, based upon when they work. There'll be some, I'm confident it'll be in some guidelines. And the scientists tend to be very conservative, so, but still, it'll be in some guidelines. And then the CPT code,
Will
category
change.
1 code process will start. The process will start. And that process is a 2 year or more process. Hopefully just 2 years, but can be. And so that's why, there's a reason to be enthusiastic, but not like, oh, we a home run. And now it's a home run. Uh, and depending upon what that number comes out to be, people are going to decide to do it or not do it based upon if that number is reasonable. It's not reasonable if it's the cost of a fibroadenoma because
Oh, for sure.
for
Yeah.
example, and
How is the cost for the cryo compared to a lumpectomy or a mastectomy cost?
Uh, I mean, surgery is more expensive, mostly because there are more components that are reflected there. There's the actual charge that the surgeon makes for the surgery, but
There's the
there's the
hospital and
hospital has
everything
a
else.
charge that it makes for the surgery.
So the
Then
overall charge is more than if you were having
yes,
cryo.
not more.
I'm
And
just thinking if patients could actually, because years and years ago, I had a child that we were told there was no home health care. So I found out what was costing every day to be in the hospital,
mm,
found out what it would cost to have the home stuff I needed. And then I went to the insurance company and I go, look, you can pay $3,000 a day, or you can pay $1,500 a day.
mhm.
And I got what I wanted. I
Well,
wondered if we
well,
could do something like that with this.
so what they say, and it's partly true and partly not true. I think mostly true, but also partly not true, is that they're not making decisions based on cost alone. I said it's only partially true, but it's they need to have the indication first. Once they have decided saying that this is an acceptable treatment, then they can make the decisions. Well, I'm going to do this one because it's more cost effective than that one. But they can't say I'm going to approve. Their policies say that they can't approve cryoablation now just because it's cheaper than lumpectomy without lumpectomy being established without
Cryo.
cryoablation being established as an acceptable alternative. So it's a little bit early, but but the answer to your question is that, cryoablation costs whatever people
Right.
charge for it. But that reflects the cost of the device, the cost of the staffing, cost of supplies,
The overhead.
overhead, all those things kind of factor into that. In surgery, there's the cost of the actual procedure. Then there's pathology and
Anesthesia.
anesthesia and hospitalization and all these other costs. And so they may end up being fairly comparable. In fact, they should be close to each other. I mean, it shouldn't be, obviously, we would hope that cryoablation is cheaper, but it shouldn't be so cheap that it makes it unattractive to the system for using it. It's not just the doctors. Like,
Yeah.
the operating room doesn't want to lose all procedures to cryoablation.
And the anesthesiologist.
Yes, right. So it has to be equitable in the sense that you can, you know, you can make a business out of it, you know, either whether you're a hospital or whether you're a provider. Um, so anyway, I think we covered that topic pretty thoroughly.
How about the DCIS
Sorry,
trial?
it's not more positive than you would like, but it's actually reasonably okay. It's just that before I would just go on that for better or for worse, innovation and all of the processes that accompany it take time.
Well, at least it's started.
Uh, and it started. And I've been doing intraoperative therapy for since 2004, since actually 2005, but I've been involved in the advocacy for it since 2004. And it took 10 years before the studies
Biomarking, yeah.
and before we had a code and before it could be freely done. And so it's a matter of time. The science has to progress along with the politics of it, and they kind of both have to arrive, at the same time. The politics, which is linked to the billing, all those things.
Oh, yeah.
So it has to all arrive, and any single one isn't enough. So DCIS was excluded because DCIS is not ultrasound visible. And so DCIS has never been included in existing trials, but I developed the DCIS cryoablation trial and was supported by your efforts and the efforts of listers here to investigate the use of cryoablation to manage DCIS. The trial is a little bit technical. What we're basically trying to ask is, can we make DCIS targetable by cryoablation? I've always felt that DCIS could be treated with cryoablation because most invasive cancers have DCIS mixed in. And when we biopsy patients that have been treated for invasive cancer, we don't find DCIS. It's killed as well. So it's not so much whether or not cryoablation can kill DCIS, although that's never technically been proven. We wanted to demonstrate in this trial that we could identify patients and target the DCIS well enough to treat it. So we got funding for 30 patients to be enrolled in this trial. Patients had to have DCIS that measured 2 centimeters or less based upon their imaging, like mammogram and ultrasound and MRI, if they had it performed. And if they had DCIS spanning no more than 2 centimeters, then we arrange for them to have a ultrasound visible marker placed at the cryoablation site. There are commercially available ultrasound visible markers, although they're not usually used. Usually the markers that are used after biopsy are mammographically visible, mostly because they're cheaper. The ultrasound visible markers are more expensive, so they only use them upon request. But for people that come in with their mammogram visible markers, we arrange for them to undergo placement of an ultrasound visible marker right next to it or in the right spot. And then they can be taken to cryoablation, targeting the ultrasound visible marker to get us to the right spot. And so we now, I believe, are at 27 of the 30 patients that are to be enrolled on the trial.
So you need 3 more.
3 more, yes. But the protocol also calls for each patient who receives cryoablation to have a biopsy done of the cryoablation site 6 months after. A couple of reasons for that. One is, as you know, after cryoablation, there's a lump that persists for some time. And sometimes people are alarmed that that lump could mean that the cancer is growing. Maybe their doctors are alarmed the cancer is growing because they can feel a lump. So we biopsy the lump just to be sure, to document that the area is benign. Number two, radiologists are often uncertain what they're looking at, so we're trying to teach them to feel confident about what they see.
Oh, yeah. Every time I have a CT scan, they comment on where I had the cryo.
So we're trying to just build confidence, give them confirmation that they can look at the imaging, they can look at pathology, and they could trust what they see. And then of course you just wanted to, it takes years to determine whether or not the treatment is successful if you're measuring local recurrence. But by doing the biopsy at 6 months, at least we could get some indication that the treatment was successful short term. And then we just have to see if people have recurrences around that area, So as of, I think, November, no, maybe October of last year, we had reached a point where half of the 30 patients, 15, had reached a 6-month time point and had completed a core biopsy of the cryoablation site. And so I wrote up that experience in a publication, kind of like an interim report is what I called it. I submitted it for publication. It's been approved for publication. And so likely will come out within the next few weeks. It went through the review process. I made some edits, and so the final review was approved. And so basically what it found is that in all 15 patients, in 14 of the 15 patients that had successful cryoablation, the biopsy showed no disease at the cryoablation site. It only showed scar. It showed some residual calcifications. It showed chronic inflammation, but no surviving DCIS. In one of those patients, the targeting was not accurate because of the problem of marker or clip migration. Yes, which happens. Meaning, she had cryoablation, so she had a biopsy done. They did this, they took out the tissue sample, they put in the marker, and the marker migrated. Now that's fine. Our plan was, well, when you come to cryoablation, we'll put a marker in the right spot because that marker migrated. So she came in, she had her marker placed in preparation for cryoablation, and it migrated. It has something to do with where it was in the breast and so forth. And so we basically said, well, I can't offer you cryoablation, or based upon the 2 marker locations in the nipple, maybe we can triangulate to the right spot. We gave it a shot. We tried to triangulate to the right spot. We just missed it. And so 6 months later, when she came in for a follow-up, there was cryoablation here, and the cryoablation, there's no cancer found in the cryoablation site, but the original calcifications were just at the edge of the cryoablation. So we missed it by a few millimeters. There was still surviving DCIS there. And she's yet to come to treatment for that yet.
Okay.
There's still being worked, deciding how she wants to do that. But at least for the 14 of the 15 that had an accurately targeted site, there was no surviving DCIS. Now, there have been other patients that have enrolled since then, and so we'll ultimately have a final report of the whole 30, ultimately. And so the other observation was that there were two patients that had recurrence outside of the cryoablation site in another part of the breast that looked normal at the time that they had cryoablation, but over time, those areas developed. And that could happen with lumpectomy. It could happen with cryoablation. It's basically a failure of imaging to detect disease where it is present. Um, that's why it's important to do follow-ups, obviously, and sample things that might be new. Um, and, another couple of details about it is that, this trial required the cryoablation, it required the needle biopsy. It did not require anti-estrogen medication,
And that might have
and
helped.
it did not require radiation. Those things might have helped. We don't know, but that reflects kind of where we are now with DCIS. That people are given the option of doing no surgery. They do surgery with radiation, surgery without radiation, surgery with medication, surgery without medication. All of these are valid options for people with DCIS now. So I didn't want to make the trial more onerous by requiring that they do a whole bunch of things that
Yeah, because
they
then you'd
would.
have trouble finding people that wanted to do it anyways.
Right. So it's, and it also respects kind of patient's choice in how they want to manage their diagnosis. And so we leave that decision to the patient and the provider to determine, whether or not they do medication or whether or not they do radiation. To help that decision, we recommend genomic testing, which is like a testing of the tumor's gene, which helps you determine what the 10-year risk of recurrence is with or without radiation. And with that piece of information, a patient is free to decide if they're going to take medication or not. At least it's a more informed consent. But that is the DCIS trial. You'll have a copy of it in your hands hopefully in the next month. But it's the first trial on this particular topic. It's been published or will be published to show that cryoablation should be offered to select patients with DCIS, and that DCIS shouldn't just be off the table because, it's hard to see. We have a way of making it visible. Any more questions about the DCIS trial?
No,
I have one more to discuss.
which one? I forgot now.
The Frost trial.
The Frost trial, that's right.
Yes.
The first one.
Yes. The Frost trial. So the backstory is that in 2009, there was a clinical trial launched in the US called the ACOSOG Z1072 trial. Long name. But basically, it was a cooperative group of surgeons that got together. They did this trial of 99 patients who were to have cryoablation followed by excision of the cryoablation site. Cryoablation followed by lumpectomy, cryoablation followed by mastectomy. Either way, the goal was to cut out the thing that was ablated so we could verify that
it was gone.
It was
It
that it could work. And so that trial was started in 2009. They published the results in 2016, and it basically showed that there was a 92% ablation rate, 100% ablation for the tumors that were 1 centimeter or less, 92% for the whole group. But the main failures were patients that had disease outside of the cryoablation zone. Like we cut out this area and there was disease at the margin, which kind of reflects the experience that I just said. It's a failure of imaging to see residual microscopic disease, which is generally why we add radiation after lumpectomy and medication after lumpectomy to treat these invisible things that may be present in the background. But since we cut the tissue out, they were able to measure, this is the cryoablation site, and just past it, there was some disease. And that counted as a failure by the trial's definition. But for the thing that was targeted, there was a highly successful ablation of the thing that was targeted. And so that was the ICOSOG trial. And when the ICOSOG trial concluded, I decided I would launch a follow-up trial called the Frost trial, which is freezing F instead of removal R of small tumors. Frost. That's kind of what the acronym refers to. And that was to be a trial where we did ablation, did a 6 months post biopsy, but no surgery. We would just follow them. The 6 month post biopsy, of course, would let everyone know that the cancer is dead, and then we would be comfortable following patients for long term to see how they did. And this trial divided the population of women into two groups. there were people 70 and older that would go undergo cryoablation and were advised to take, strongly advised to take anti-estrogen therapy. And there were people between 50 and 69 who had cryoablation, anti-estrogen therapy, but also had to have a lymph node biopsy and radiation, because these are kind of a higher risk group, at least theoretically speaking, based upon what we knew at the time. And so we enrolled people in both categories. There were 11 sites that participated in this multi-center trial. I was the lead investigator in the trial. And the trial was sponsored by a company called Sonaris, which is a company that made the first cryoprobe that was used a lot in the US. This is a company that also got the indication for the cryoablation for fibrinomas. So they did a lot of work the first 10, 15 years, like between maybe 20 and 2015. But because of this struggle to get this indication for cancer, they couldn't survive. And so they were bought by another company called Hologic, which you probably heard a lot about. They're not the big fish. Hologic bought the company and bought the technology, obviously, but didn't
want to go on.
Didn't want to continue the trial. The cryoablation trial started in 2016. The Frost trial started in 2016. The company Sonaris, I think, was bought by Hologic like 2018, 19, maybe. And so and so we were faced with, well, what do we do about the trial? We enrolled these patients. We had planned to enroll 200. We enrolled 84, 85. What do we do now? And so there was this 2, 3, or 4 years of limbo where there were no more enrollments. The IceCure study had just started, the one we talked about earlier. So they didn't have any data yet. And I basically went to the company and I said, there's a side story to that. But at least regarding the Frost trial, I say, I know you're not interested in funding the Frost trial. You're still trying to figure out what you want to do with this technology. But I want to continue to follow up with the patients. So I would like you to empower me, since you technically own the data, empower me to, reconnect with all of the doctors who were participants to get long-term data on the patients so that we can ultimately respect this trial and the patients that participated by reporting the long-term outcome. And they agreed to do it, but it took them about 2 years for them to find the data and get the data to me, because it was somewhere hidden in the files of the company that they bought, and no one really knew what the data were.
They didn't really care, probably.
It wasn't a priority, but fortunately, there was someone who was listening, and so I eventually got a couple of USB drives with the patient data on it, and it was quite valuable to have it, although there were parts that were incomplete, but at least I got that. And so literally for a year, but in kind of intensively the last 6 months, I've been trying to track down all 84 patients that participated in the trial. It's been, emails sent to emails that don't work anymore, phone calls to phone numbers that are disconnected, certified mail sent to addresses where no one lives currently, or at least the patient doesn't live, using private investigator search platforms to find next of kin of patients. Of course, going back to the doctors, but some of the doctors have moved on from where they
or retired.
And if they move on, they don't have access to patient records anymore. They don't have access to those patients because they can't get into the chart anymore. The chart belongs to the hospital, not to them. So it's amazing I've been as successful as I have been in contacting every living person who was on the trial. There were 3 people that died, not of cancer, but died of other causes. But there are 84 patients that all 84 have been accounted for. There's still some additional data I'm waiting from 2 different sites, but we kind of have the long-term follow-up. And so I submitted an abstract or a proposal to the American Society of Breast Surgeons, the upcoming meeting in May, to present the long-term data for the Frost trial. That meeting is in May, and I submitted the abstract. I'm still waiting for their decision regarding it. But it summarizes the experience of the 84 patients. And there are 3 deaths, non-breast cancer related deaths. There were 3 recurrences, 2 invasive cancer recurrence, and 1 DCIS. One patient had DCIS that developed in the same part of the breast. But that works out to about a 3% recurrence rate, 3.5% recurrence rate over 6.5 years, which again is like the IceCure data, just the follow-up is a little bit longer for the Frost data. And it's like the other trials, where patients generally got no radiation therapy. I think our numbers were about 54 patients were in the older group, 36 patients were in the younger group. The young group got radiation and lymph node biopsy. But these are pretty good results.
Yeah, they are.
Yeah, and for long follow-up. And I had a really wonderful moment yesterday. Even though I failed to reach a lot of patients, I still keep trying. And so there's this one number I said, I'm gonna try it one more time. I've tried it multiple times before. I tried it one more time, and I got a voice message in Spanish.
Oh,
I didn't know what it said because I don't speak Spanish. But I then asked
I guess Alba did though.
well, I asked one of the people in my office to call the number and at least see what the message was. I mean, because this patient has been lost since 2018. No one's had any accounting of her. The last data I have for her was from 2018. I kind of given up on it, but I said, let's try again because I'm persistent.
Yeah, I know.
And so she called this patient's number, and it was a patient.
Oh, wow.
And she called me, she got me on the phone with the patient, and the patient was doing fine and has no recurrence. And she was delighted she had the treatment, and she was very thankful. And it was like, just felt so lucky because if I couldn't reach her, I didn't know if she was dead. I didn't know if she had developed breast cancer. This is important information to know. And not knowing it was didn't leave me feeling didn't leave with a good feeling. So it was like, it was so wonderful that we were able to find her and verify that she's fine. And anyway, that's the Frost trial, and it'll be out soon.
Are you going to speak on it at the conference?
Possibly. I mean, frankly, I submitted as an abstract. It's called a late breaking abstract, things that come. The deadline was in November. But this is kind of late breaking results, so they consider certain things whether or not they're worth even presenting as a poster. But I'm really looking for them to invite me to present it as an oral. I actually won't present it. I probably have my research student present it, who worked on the project, but have it as an oral presentation. And if they don't want to do it as an oral presentation, I'll just publish it. We don't need to present it as a poster. We just write it up and get it published. But but one of the requirements is that it can't be accepted as an oral presentation if it's already been published or if it's already been submitted. So I'm holding back any publication of it for decision about this presentation. And if they accept it as a presentation, we will present it and then publish it.
Interesting.
Yeah. So that's what's going on.
How about my pet peeve that I just wrote a paper on?
What's your pet peeve? Tell me about it.
Dosing.
Yes.
Overdosing patients.
Yeah.
Because most of the oncologists, because I actually researched it and I went to San Antonio and I have the research that they did and all the clinical trials, for some reason, they always go for the maximum tolerated dose, which who knows what that is. That's kind of a subjective thing.
Yeah, yes.
I mean, I certainly don't want the maximum tolerated dose of anything. And I was really pleased to see that at San Antonio that they are starting to do trials on it and look at it. And the interesting thing was the one that came up and that they actually did was on the medication I've been taking. And when I took it, I refused to take the full dose, taking 2/3 the dose, did it 2 years ago, had a 4-centimeter lesion in my liver, and it was gone in 4 months. So obviously you don't always need the maximum tolerated dose. So that's been like my little pet peeve. And And I just wrote a paper on it and I haven't heard anything back about it yet, but it probably will be published like on the Alamo site. I'm not sure where they publish them. I just know they said they
Mhm.
publish them, which is kind of cool.
Well, I think they
I've
should.
never done
I
that
thought it
before.
was well written, and I learned some things from that because I didn't know about sort of the movement in the medical oncology community to de-escalate therapy. That's what we talk about a lot in surgery and in radiation about kind of, not giving the maximal treatment, but trying to figure out, how much we can reduce the treatment and still get the same benefit. So it was good to read, you know, about it and that there's interest in
And a lot of it
progress.
came up because of the patients complaining.
Well,
It
all of
was a
this,
patient that went and started one of the groups and they've gotten people to listen.
all of this is about patient complaining. I mean,
Yeah.
we're advocates, but we're advocating for patients because they express concern. So keep complaining. That's the only way the squeaky wheel gets the grease, as they say. But you know, the idea of de-escalation, it's driven by patients, who are saying, I don't want to accept that. Give me something that is more acceptable to me.
And I mean, some patients probably pass away because they don't want to do it.
Yes,
I have a
yes,
friend right now whose name I won't mention, but she's been suggested by her oncologist to take, or the oncologist she was seeing, to take the same medication I am. It's called Zolota. It's a pill, a chemo pill. And the doctor told her, but you will get blisters on your hands and blisters on your feet and blah, 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 the
Mhm.
whole. And so she won't do it. Now she's switched and she's seeing my oncologist now. And I told her, I said, I've been encouraging her to do it,
Mhm.
but do it at a lower dose like I did.
Mhm.
Because I have what looks like eczema from it,
Mhm.
but I don't have blisters and I can walk. I don't have blisters on my feet.
Mhm.
And actually, when I asked Dr. Chap about it, she said, well, usually that's because they're getting too much.
Mhm. Mhm.
So, well, I've been really blessed all the ways
Mhm.
with everything, but yeah. And like, I'm never going to do chemo person, but when you suddenly find your stage 4, because you had this nasty, ag aggressive kind, you got to start looking at what you need to do
Mhm.
and mix the integrative with. So I found a really good way to integrate
To
the
balance.
holistic with tolerable chemo stuff or
Mhm.
whatever is standard of treatment. But I always say, you know what, I don't want the full dose.
Mhm.
Because what a lot of people too don't realize is I have something called a methylation problem.
Mhm.
And my sister has it, my husband has it. It's how you process medications. And so we don't necessarily need the maximum tolerated dose.
Mhm.
It might be more of a problem than,
Well, that can work to your
it's
advantage.
just,
Maybe. Yes,
except most doctors don't know about methylation issues,
that's right. Right.
which was really nice for me because at the time I had a reoccurrence of the stage 4 of the in the lungs. And when I had the reoccurrence, I didn't want to take the maximum dose of the medication I was going to take. In fact, I wanted to take a different medication. So I asked my oncologist to call my primary care doctor, and she was quite willing to do it. And that night, she called me back and said that they had decided on whatever.
Overdose, yes.
So it's like it really needs to be that I think all of your providers have to interact with each other. And if they're not willing to it, then it may be time to move on.
It's certainly helpful. It should be, both on your team, working
Well, yeah,
together
because
collaboratively.
they all have different, I don't want to say specialties, but different knowledge
Mhm.
depending on where they've been. And my primary care at the time had worked with a lot of cancer patients and had actually had a cancer center where she had, treated for years.
Mhm.
So she knew a lot.
Mhm.
And my first oncologist didn't like that. She just wouldn't take that at all. And
I remember her.
yeah,
Yes.
she was,
Yes.
yeah.
Mm.
So I've learned that everything is, I mean, what I tell all the
Well, you should
patients,
send her a copy of that paper.
yeah, I should, huh?
Yes.
And I will. Um, what I've learned, and I tell everybody, is because you know what, people can't when they first get diagnosed, they usually get depressed and have a really hard time. And I didn't do too much of that. I probably had it worse when I got stage 4 and you talked me out of it at midnight. But what I've learned is knowledge is power. The best thing you can do is research what kind of cancer, breast cancer it is, because most of us, before we get it, think that the breast cancer is breast cancer, and it's not. There's a whole variety of different types. And then research it, research what drugs are or what's available to treat it, so that when you deal with the oncologist, you know what you're talking about. And the more you know, the better. So knowledge is power and attitude is everything. So you have cancer. I live like I don't have it, but I do what I have to do to take care of it.
Mhm.
So I'm actually having, I always call it, this is my best life ever.
Mhm.
So I've actually had a better life out with cancer than without it.
Yeah, and counting your blessings as well. That's
Yeah,
good.
so it's like you look at the silver lining, because for one thing, I think your attitude makes a difference in how long you live and how well you do. And secondly, I think why waste your time being miserable when you don't know how much time you have?
Mhm.
Enjoy it.
Yeah. Well, that sounds like a perfect topic to end on.
I mean, heck, I'm going to Philadelphia in a couple of weeks for the metastatic conference. Living, what is it, LBBC, Living Beyond Breast Cancer.
Mhm. Mhm.
And then
It's a great idea.
yeah, and I'm hoping to this year to also go to Lynn Sage again.
Mhm.
That was fascinating because you get to hear all the investigators and what they're doing.
Mhm.
And then I also I loved going to the San Antonio Breast Cancer Conference because they're from all over the world. I met all kinds of patient advocates and got to hear all kinds of interesting things. And now I have even more connections.
Mhm. Well, hopefully you have time for a webinar in a couple of months.
Yeah, of course.
Or maybe next month. We'll have to figure
Well,
it
next
out.
month I'm
Yes.
going to Philly, and then the month after my husband and I were going with you to the breast cancer one in Vegas.
Yes, yes, yes.
This breast
So,
cancer surgeons one, I
yeah,
should
the American
say.
Society of Breast Surgeons meeting, the one where hopefully the frost data will be presented live.
And I'll have to go listen.
Yes, you will, you will.
And it's
Fingers
just,
crossed.
oh, and I love going to the conference. I get to
Mm.
hear from all the people that knew you years ago. I get to hear all the stories.
There are lots of stories. Uh,
Yes.
but so
All
thank you.
positive though.
Thank you. Thank you.
They actually think very highly of you.
Mm.
And I think the guy who runs the Breast Cancer Society, he told me that he wants you to be the next to take his place when he retires. So,
Well, my agenda is full. My plate is full.
but it's a compliment though.
It's a compliment. Thank you.
And he
Thank
told
you.
me how hard you worked in school and
Mhm.
how just you told me lots of good things.
Thank you. Thank you. Enough about me now.
Okay.
Uh, so we'll find a date in the next 1 to 2 months,
And a topic.
a topic. And thank you for your time today. Thank you for your time, for those listening now and for those who listen in the future. This will be posted hopefully by the end of tomorrow and made available to those who want to know more about it or see it again. Thank you so much.
Thank you too.